Ja. Goedenavond, welkom allemaal bij deze webinar over de Britse variant en wat kunnen wij in Nederland verwachten. Voor ons een van een belangrijke webinar waarin we eigenlijk wat meer willen vertellen van wat kunnen we in Nederland verwachten, hoe bereiden we ons voor. En we zijn heel erg blij dat we een spreker hebben, Flo Panel Coates, uit het Verenigd Koninkrijk. Flo is Chief Nurse in University College London, waar ook Marcel Levy werkt. Vanavond zal dit webinar deels in het Engels zijn. Het gesprek met Flo zal in het Engels zijn en ik zal ook tussendoor proberen te vertalen. Misschien even nog voor de introductie. Mijn naam is Bianca Buurman en ik ben de voorzitter van Verpleegkundigen en Verzorgenden Nederland. En we hebben vanavond ongeveer 500 deelnemers online. So I'll switch over to English to welcome Flo. Flo, we're very delighted to have you here tonight and to have the conversation about the British variant of the coronavirus, the impact it had in the United Kingdom, and also what we can learn from it in the Netherlands. Very, very welcome. And I think it's really good to start with an introduction. You work at University College London as a chief nurse and also an executive lead for emergency preparedness, resilience and response. So that's a whole mouthful of words. So can you tell me a little bit more about what your role is in University College London?
Good evening, Bianca. Thank you for inviting me to kind of share some of our story. And I think this is a really important time for us to learn from each other. So I enjoyed our conversation recently where I also had the chance to learn from you. So I've had the pleasure, I've been the chief nurse at University College London Hospitals in London for almost 6 years. It's my fourth chief nurse role, and one of the great things that I've had to do in the last few years is also be the executive lead for making sure that we're ready for anything that might happen untoward. So any sort of incident, terror attack, unfortunately we still have to be prepared for things like that in the city, but also any failure, so any failure of services. And then more recently we had two big things that I've been involved in. One was planning to leave Europe, which has been a great personal sadness, but we are where we are with that. And more recently, the work around making sure that we have done everything we can do to respond to something that's been unknown worldwide, which is the COVID-19 pandemic. And there's the big man himself. I've had the pleasure to work with Marcel for over 3 years now since he's joined us as our chief exec. So that in itself has been quite a pleasure.
So a huge role, I think, and working also with Marcel. We have heard a lot. So he has talked about you in Dutch media as well. So that's maybe good to know.
Oh, sorry about that.
In a very positive way. So that's also good to hear. So can you tell us, so because you're like, so you had the British variant already like since October. We are currently preparing for it. We will show some numbers, Dutch numbers a little later. But can you tell something about like the situation you had, the differences with the first wave you had last year? So what was the difference with beds occupancy? Can you tell something about that?
Thank you, Bianca. So there's a few things that were quite different. Obviously, the first wave, we didn't really know what to expect. We were watching globally what was happening, how countries were responding. And I remember us being very avid watchers of what was happening in Europe and in particular Italy, which had hit a peak before we did in the UK. So the big difference you'll see from the diagram on here was that we thought at the first peak that was the most we were ever going to experience. So we'd increased our critical care beds, that's the blue number. We'd increased the patients that we could look after in other settings. So, sorry, the blue number is the ward number. So the red number, the green little colours there is the number of patients that we looked in high dependency or respiratory units. So we'd opened some beds in the first peak, and then we'd increased our capacity significantly in the second peak for ICU. And that was, I think, probably one of our biggest challenges was the level of increase that we had to increase by, which meant that we were occupied in 4 different areas in our organisation. The first time was just in one of the wards and theatres. The second time we were in 2 wards, theatres, and one of our other ICU units on one of our other sites, which helped us as well. So big difference. So we went from base of 62 intensive care beds and increased that up to 123. Although it felt very close to the wire, we only maxed at 118, and we did that not just for our own organisation and local population, but other parts of London where we were providing something I'll talk about a little bit later on, which is a lot of mutual aid. Lots of Cpap facilities. We learned a lot about that level of respiratory support. I know, similar to the Netherlands, that actually we've learned so much about how early intervention, good Cpap support, good antibiotics, great treatment meant that a lot of patients actually were really well looked after in those facilities and didn't need to be admitted to ITU. So we knew that the patients that ended up in ITU ventilated were very, very poorly.
Yeah. So if you compare it for like the first wave and the second wave, if you see it, it's like way more than like in the second wave than in the first wave. It was almost 60% more patients. Is that right?
That's correct. Yes, both in terms of inpatients and in our specialist units, which was significantly higher. So yeah, about 60%. You're absolutely right.
Yeah. And we will talk about it a little later, like, yeah, so how can you really prepare for that? And like, what was the impact on the nurses? What I will try to do is translate a little bit in the Netherlands and then also show what we are expecting in the Netherlands. And so, yeah, as you know, we are like going to a 3rd wave, and this is with the British variants of the coronavirus. So what I will do is switch over to Dutch, then translate a little bit about what you said, and then show the Dutch numbers, which I will also do in Dutch. Zo misschien goed om te zeggen is wat Flo vertelt, is ja, dat er een duidelijk verschil was tussen de eerste golf en de tweede golf. In de eerste golf was nog heel weinig voorbereid. Dat is in die tweede golf eigenlijk veel beter gegaan. Dus er was al veel meer geleerd van de eerste golf. Tegelijkertijd is in die tweede golf werd ook gezien, zeg maar, dat er bijna 60% meer patiënten waren dan in de eerste golf. En dat heeft eigenlijk ertoe geleid dat ze heel veel meer IC-bedden hebben moeten creëren. Maar dat ze ook buiten de IC bijvoorbeeld de Optiflow hebben ingezet. En dat is natuurlijk ook wel vergelijkbaar met wat er nu in Nederland gebeurt. Sebastiaan, misschien naar de volgende slide, want dan laat ik wat zien over de Nederlandse cijfers. Dit zijn cijfers van het Landelijk Coördinatiecentrum Patiëntenspreiding. En wat je hier ziet is de 2 lijnen. De blauwe lijn, dat is de normale variant. Wat je ziet is dat die afneemt. Dat zie je met de R-waarde en die R ligt onder de 1. En dat betekent eigenlijk dat er steeds minder patiënten zijn met het gewone coronavirus. En dat is natuurlijk ook als gevolg van de maatregelen die er zijn. Het tweede wat je ziet is het aandeel van de Britse variant. En wat je ziet is dat de R-waarde van die Britse variant dat die nu op 1,13 ligt. En dat betekent ook dat het langzaam aan het toenemen is. En wat je ziet is dat snijvlak tussen de blauwe en de rode, dat eigenlijk in deze week ligt. Dus vanaf deze week neemt de Britse variant de overhand. En zoals het er nu uitziet, als we deze maatregelen die we nu hebben aanhouden, dan zie je dat tot en met 6 mei dat we niet boven de eerste golf uitkomen. Dat zou heel goed nieuws zijn, maar ja, heel veel van jullie weten ook dat we aan het versoepelen zijn, dat de scholen weer open gaan en wat nog niet bekend is wat de effecten daarvan zijn. En daarom laat ik ook een tweede plaatje zien. Sebastian, kan jij naar de volgende slide? En dat betekent zeg maar dat er nog onzekerheden zijn. Als we verder gaan versoepelen en bijvoorbeeld de opening van de scholen leidt tot een verhoging van de R-waarde, dan komen we daadwerkelijk uit boven waar we nu zaten. Net zag je dat het ongeveer op 100.000 kwam. Dat was wat we in de tweede golf hadden. En waar we nu op aan het voorbereiden zijn, wat mogelijk zou kunnen gebeuren, is inderdaad dat we echt een derde golf ingaan, waar we net als in Engeland heel veel meer patiënten gaan zien. Dus dat is de situatie waarin we zitten in Nederland. En ja, dat is nog een onzekerheid, maar ja, als we wel in dit scenario komen, dan kan het echt wel hele serieuze consequenties hebben. En daar gaan we het ook vandaag wat verder over hebben, want dat is ook de situatie zoals ze in Engeland hebben meegemaakt. Okay, Flo, I will switch over back to English. What I told is that there's still like insecurity in the prognosis. So we are not 100% sure that we're digging into so we're getting into the third wave. But we don't know, because of the coronavirus. How do you say the rules or the regulations, or the lockdown regulations? Yeah. So it's dependent on so how do we extend them if we're getting into the third wave, and to what extent, so in what kind of situation we're coming, if we're getting into the situation you were in, but we are currently preparing for that. So I would like to ask you a little bit more about, can you tell us a little bit more about the impact on nurses, and what did you do to prepare them, to prepare the teams? Because could you see it coming, or we
did see it. Yeah, so we did actually see it coming. However, I think we kind of dreaded it coming, if I'm honest. So we knew there was a likelihood to be a second peak. We were worried that it would be as bad as the first one. What we didn't expect is it to be actually higher. And to last for longer. So it's been a higher peak, but it's also, we've been at that peak we were at it for a lot longer than the first peak, where we spiked and came down quite quickly. Impact on nurses, I have to say it's variable. It's hugely variable, depending on, as you would expect, how you arrive at the beginning of a kind of stressful time like this. And you couldn't always guess how people were going to respond. I suppose what I've put here is two pictures. The biggest two things that I've seen more than ever is the moral distress that our nurses and other clinical staff have been under. But if you think about the amount of time nurses spend with patients, and actually some of our other staff can arrive and leave again, but actually our nurses are the ones that are intensively at the bedside in intensive care unit and some of the other facilities. The moral distress of three things. One is the virus itself was quite upsetting, and the way that we have to treat patients, particularly proning, was something that was quite distressing. Less so the second time, as we've become a little more desensitized to it. One of the big elements was actually witnessing distress in other healthcare professionals and teams. So it wasn't just looking after your patients, looking after yourself, but at times it was also being available to look after others. And the third thing was around the ability for families and relatives to be able to visit. And we, as much as possible, particularly before patients were ventilated, we tried to allow the family to come in and speak to the patient before they were put on a ventilator, and that in itself was quite quite distressing for those around, for the family, and then the volume of deaths would be the other thing. So obviously patients do die when they access our critical care units and others. It's, you know, they are the sickest, most unwell patients, but the number that died compared to the ratio, it was, you know, in a few months what we would experience in a year, and it was intense. So and then how to prepare, lots of different things, but I thought I'd just remind myself, really more than anything, of how important it was to really think about some of the kind of real fundamentals. I've put Maslow's hierarchy of needs. Not everyone likes Maslow's, but it's always a kind of helpful reminder around how important some elements are, particularly if they're absent, and making sure that people had rest, food, water. I know myself, being in the PPE, personal protective equipment, for hours, 5-6 hours at a time, it's exhausting. You become dehydrated. It's hard work, it's intense. So we try to think about all of the levels of Maslow's hierarchy of needs. Do they have food? Can they have a break? Can we get more staff available, even if they are staff doing other tasks, to allow for a more frequent handover so they can have breaks? Do they feel safe? One of the things that we did is write to every registered nurse to say, we know that it's going to be really tricky for you to deliver the same quality and standard of care in pandemic times than you would every day. I personally wrote saying I carry that responsibility with you, because many of our professionals were worried. They were worried that if there was work left undone, they would be held to account, or if a patient had acquired a pressure ulcer from their Cpap device, that they would be held to account for that. We tried to create environments for them to have time away, but obviously still had to socially distance, because we found out very early on that it's that people were very well protected when they were in the clinical environment, but they left. They went into the coffee room, everyone was relieved, they were friendly, sharing food, being kind and supportive to each other, and actually there was some cross infections that way. And then just moving up, giving people the kind of recognising, rewarding, making sure they have the kit they need, making sure they have trained people. And the really big thing was making sure they didn't feel like they were doing it on their own. That's what we learned from the first wave to the second. We were much more organised around rosters, registered professional staff, ward staff who were trained and prepared to come into the environment, so they knew that they would be called upon, and were willing to be called upon, so that they would be able to support certainly the night shift that I worked recently. There was 3 nurses, so there was one critical care trained nurse, 1 ward nurse, and myself, and a dental nurse was helping, and brilliant team. So that one team was really important.
Yeah, so it's really about looking at so what we recognize very much, I think, is the moral distress that you cannot deliver the care actually that you want to deliver, and so then and also with the high number of deaths, and actually what you're saying, like the importance, what you learned from the first wave, is really to act as a team and really to prepare. And yeah, that you start with the basic needs of nurses, and then the food, water, rest, but also like the safety and how can you really be a team and acknowledge what is going on. Can you tell something also, because it actually, it's 60% more people, so that is really a lot. And if we now think about that, so it's really hard to imagine how much that is. So were you confronted with ethical dilemmas of care that you couldn't provide, or yeah?
So at a very kind of national level, we'd invoked the National Civil Contingencies Act, which meant that as part of our emergency planning, that if a patient needed a critical care bed, that they would receive it. But it did mean that some patients had to move out of London. So initially we tried to make sure that we were able to look after people within our part of London, North Central London. And then we tried to keep those patients in London. And when that was really tricky, particularly in January, when we were at our peak, we did have some patients did have to move out of London into the Midlands, and we also reciprocated that, so returned by being able to do the same when we settled a bit and they were in the peak. So I think the biggest ethical decisions we were making was around visiting. We were very lucky that we were able to get the equipment that we needed. There was always a worry, there's a kind of a fear that we wouldn't have what we needed at times, particularly the first wave. By the second wave, we had a better idea of what we needed as well, so and where we would have it, and then a little bit more confidence because we were able to deliver when people needed it. People relaxed a little bit more, so they were less worried about that. I mean, certainly we were able to offer the patients the treatment they needed, and we rely heavily on what we do every day as clinical teams, which is we make decisions every day based on what's the right thing for the patients, but it wasn't based on whether or not we had enough resources. It was always about what was the right thing to do in this instance for this patient.
So, and actually what you're saying, even though it was like a lot more patients, you have never landed in the situation that you had to triage for the ICU and you could not admit patients to the ICU anymore. Is that right? Or you could not, because we've seen the pictures and in the news, like about the crowding ambulances standing in front of the hospitals, and so I mean, it's so, yeah, if we just were looking at it, it's
So that was our fear. Obviously, that was why some of the national centres were opened in the first wave. The Nightingale hospitals were open because of that fear, that if patients really needed treatment, they wouldn't get it. One of the limiting factors is always staff, not just equipment, not just facilities. Certainly, we had to work really closely as a system to make sure that we knew where those delays were. So, for example, there were times in one of our local hospitals where they had a population that exceeded their capacity, and we were directing those patients to us or to one of the other surge sites. So we planned for that. And actually, we were on calls 2 or 3 times a day up until quite recently, actually, making sure that we were able to facilitate the movement of patients across London. We brought in our own we created our own transfer teams, so that we were able to not have to rely on the national ambulance service, who are brilliant, but they were already under pressure, so that we could actually transfer patients between our sites or across London, so that those patients who really needed treatment were able to get it. And we were worried. We were worried that, particularly when we're getting close to what we set up as our super surge, so we went from surge to super surge. But I'm really pleased that we didn't have to make those really difficult decisions.
Yeah. So Flo, what I will do is translate some of what we talked about in Dutch again. Dus we hebben het eigenlijk met name gehad over wat is nou de impact geweest op de verpleegkundigen en in het ziekenhuis. En hoe bereid je hier nou eigenlijk op voor? En wat Flo eigenlijk zegt is, in welke ethische dilemma's heb je nou voor gestaan? En wat ze eigenlijk zegt is, en dat denk dat veel van jullie dat ook wel zullen herkennen, is dat die morele distress, dat je dat ook, dat ook heel vaak ervaren is. Hè? Van toch het gevoel van tekortschieten, dat je niet familie bij het bed kon hebben op het moment dat je wel vond dat dat nodig was. Dat je toch bang bent om zelf besmet te raken of iemand te besmetten. Dat zij wel heel erg gezien hebben, en ik denk dat heel veel van jullie dat ook herkennen, dat het heel erg gaat over hoe zorg je nou dat je een goede balans tussen werken en rust vindt? Hoe zorg je dat mensen goed beschermd zijn? Maar hoe zorg je ook heel erg dat je dat teamgevoel en echt het werken als een team ook heel erg stimuleert? En wat ze ook benoemt echt is van, ja, vanuit die eerste golf hebben we ook wel heel erg geleerd, ja, hoe je daarop kan voorbereiden en hoe je dan, ja, hoe je daar ook goed in traint. Wat ik ook nog gevraagd heb is, ja, uiteindelijk zijn jullie nou in een situatie gekomen waarin je echt bijvoorbeeld mensen niet meer op de IC op kon nemen of niet meer in het ziekenhuis op kon nemen. En zij hebben niet in de situatie gezeten, ondanks dat ze 60% meer patiënten hebben, dat ze geen mensen echt niet meer op de IC konden opnemen. Dus dat, nou ja, ik vond dat zelf wel, toen ik het hoorde, in ieder geval enigszins geruststellend. Dat je het dan toch nog met elkaar kan redden. De vraag is natuurlijk wel van, ja, wat is de lange termijn impact? So okay, I'll switch over back to English again, Flo. So we talked about like what is needed for the teams, what is needed. So did you experience ethical dilemmas, yes or no? So can you tell us something about like how do you I mean, in the first wave, like it was totally new. You learned from the first wave to prepare for the second wave. I mean, you thought that like it could never be as bad as in the first wave, but it was worse. So your preparedness. So what did you do, and how did it help you to be able to handle those extra patients?
Thank you, Bianca. So we did things at every level, actually. So one of those things was the strategic incident management group that I chaired with Marcel daily. A big part of that was being able to make decisions really quickly, or bring together subject matter experts to be able to give them the support they needed. Many of the ideas actually came from those staff. A lot of the preparation we did, so we knew that we'd need lots of staff. We'd modelled that based on our worst case scenario, and the numbers looked really scary. I've got to say, when we saw we'd need hundreds of additional registered nurses or registered clinical professionals, we did think, how would we do this? But as we moved into the waves, we basically did it in bite-sized chunks. So the first group of people that went in to help were staff that had either already worked in there before and had additional training, or we'd given some additional training to be able to work under the supervision of a registered critical care nurse. So we were able to do that. We were learning every step. We were much more organised about things like the bed space, what we needed to be there, what made it easier. We've got an excellent electronic health record system, which I thought really helped, because many of us were familiar with that. So there were some things that we could all do. I know myself, I was able to do drugs administration. I might not have been able to look after a ventilator, but I could do many of the other tasks. We also released a lot of our junior doctors in training. They were absolutely fantastic. They provided a lot of fundamental care. They either did that as working alongside the nurses. It's been a brilliant experience for them and for us. I think we'll have relationships that we will build on forever, as well as recognising that we did what we never used to do as nursing, is we reverted to lots of task teams. So one group were family liaison officers. So they would be responsible for ringing the family every day, giving them an update, letting them know what happened after the ward round. We also had other groups of staff that were proning, providing some basic fundamental care. That made a big difference. And we really held our nerve. We closed all of our theatres, except for we were able to still do some things on our COVID protected green site. But they were priority ones, cancer patients who would have died within 6 months if they hadn't had the treatments they received. And without a doubt, I know my last slide was very much about that one team. It really was about making sure that people had more help. And talking to my matron for critical care, that's the thing that she's told me was really different, is they didn't feel like they were on their own, but we did wrap around them as much support as we could do that. Staff were donning and doffing, receiving staff, inducting them into the environment, proning teams, all those different types of jobs.
Yeah.
And actually one of the real big challenges was managing the rosters.
Yeah.
Because we also had some staff, some registered nurses that came from our specialist hospitals. So our Great Ormond Street, which is a children's specialist hospital, Moorfields, which is a ophthalmology specialist hospital, they also came to help us. Some helped in ITU if they'd had experience, some helped in other areas, so we could release more staff to go into the critical care areas.
Yeah, so it's really a lot about preparation, training, and actually what I hear you also say is like what we did in the first wave really, so what we learned from the first wave in the preparations really helped us to handle this. So, and you talked about task delegation, and really looking at like calling families, turning patients, bringing food, so that like you really function as a team to help out. Yeah.
There's one really important thing that I didn't mention, which was the one important thing I didn't get a chance to mention, and forgive me, was the role of pharmacist as well. So yeah. We had a lot more help from pharmacists who prepared more drugs, so that actually the time that a registered critical care trained nurse had to be away from the patient was significantly reduced. So they only had to collect something rather than to produce it ready for administration. That made a massive difference. And actually, we're still learning. We just created a real curiosity about what else could we do? How else could we get this better? What are people saying? What's great? What's not so great? And how do we respond? So we just try to stay agile.
Yeah, and it's also about listening to what is going on in the hospital and the worries of the nurses and addressing that. I will try to translate it again to Dutch and then so wat Flo eigenlijk zegt is van wat hebben ze eigenlijk gedaan om te zorgen dat ze ook die zorg konden blijven leveren. Daarvan zegt ze ook van we hebben eigenlijk heel veel geleerd ook uit de eerste golf. Engeland heeft dit was de tweede golf in Engeland. En ze zal zo ook nog wat vertellen over het vaccineren, want zij komen waarschijnlijk niet meer in een derde golf. En wat ze eigenlijk benoemt is van, doordat we mensen zo goed getraind hadden en ook met name teams maakten van zowel verpleegkundigen die dan samenwerken met ondersteuners, zowel op de IC, maar als ook op de afdelingen in het ziekenhuis. Dat heeft heel erg geholpen. Dus mensen die echt ook helpen met familie, bellen, patiënten draaien, het geven van medicatie. En ik denk dat dat ook goed is. Dus eigenlijk wat we ook in de afgelopen periodes gedaan hebben, in de afgelopen golven, dat kan ons nu ook weer heel erg helpen. Nou weet ik ook dat er heel veel mensen vandaag aanwezig zijn die niet in het ziekenhuis werken. En we gaan nu eigenlijk over op het stuk van wat kan je ook nu buiten het ziekenhuis doen en hoe hebben ze dat gedaan en hoe zet je die samenwerking op. So Flo, so you are working in the hospital. Tonight we also have a lot of people that are not working in the hospital. So they work in nursing homes, as community nurses, in the GP practice, in the ambulance. So what can you tell? What can you tell about the collaboration and so how do you build? So how do you make sure that that everything is keeps flowing and how do you collaborate with each other?
So thank you, Bianca. Your translation is fantastic. I'm embarrassed by how little Dutch I know. Forgive me.
We don't blame you.
I need to work on it. So a couple of things. One is we'd already established quite a close relationship with our part of London. I'm part of something called the Health and Care Cabinet. So we were already meeting to kind of make decisions about the way we do things and the way we shape services. What we were able to do is to come up with a more frequent way of being able to meet with a similar group. So GPs, our clinical commissioning group, community services, other acute trusts, specialist trusts, and that made it, and London Ambulance Services, little picture there. So of our London Ambulance Service as well. That made a really big difference. We also, as a group of chief nurses, we created the good old-fashioned WhatsApp group. So we were messaging each other most days at times to check in on each other, to check we were helping each other, to learn from each other, particularly around things such as personal protective equipment or devices, or when new rules were coming out, which were coming out very quickly at times. Often we wouldn't have even received the formal notification of a change in policy, but we would see it on BBC News. So we were looking out for that with each other. So we spent quite some time. We also tried as much as possible to kind of keep things moving. So if patients didn't need to come to hospital, we've got some brilliant out of hospital services. We tried to keep people at home. We did at times move equipment and particularly PPE to different parts of our system, community, ambulance service, at one point even the police, where they were struggling to keep themselves safe. So luckily we had an established relationship and we just built on that. People are very kind and supportive at a time like this, is my experience. So people want to help each other.
Yeah, so you really, and I know that is like because like also the English healthcare system, the British healthcare system with the NHS, you already collaborate a lot in the network. So that is like, so I think, yeah, that is much more a basis that you, so at least
we're getting better at it. So we are.
Okay. Yeah.
COVID's been a real leveler. So
yeah,
because actually it doesn't matter who you are, where you're from, how much money you earn, that actually everyone was worried about the same sorts of things. Obviously there are some parts of our population who have been more at risk based on underlying health conditions, living in multiple dwellings, households, our homeless population. So there have been a risk, but actually the virus itself has kind of leveled it quite a lot, and the way that we've helped each other has been, it's been phenomenal. We talk a lot about some of the things that have been really challenging, but there's been some really great things as well. We've kind of tried out policies we would have liked to have done a long time ago. We've moved staff around, we've moved patients around. It has been quite unifying at times, and some of our staff feel a real sense of purpose in the work that they have done in the last 12 months. And I know that that's been a cost for some, well, for all of us, but at different levels. But actually, there's a lot of people that are very, very proud of being able to help our local population and each other in the way that they have.
Yeah, so it also created unifying, something really unifying. That's actually what you're saying. So what I will try to do again, now maybe one question. So can you tell something about like, because you have seen also like it is crucial that like if you collaborate in the network that things are keep flowing, and we saw the lines of ambulances staying in front of the ED. So what was the main problem there? Was it actually that people couldn't get, so was there no staff, were there no beds, was there no personnel at the ED? What was the main reason? And can we learn something from that also, maybe with advanced care planning? So like, can you do some things to make the crowding difference?
Thanks, Bianca. I mean, everything makes a difference when you get into a pandemic. So every little opportunity, from from community services, great GP, so great care out of hospital, really good response from our ambulance service, making sure that only the patients that really need to be in hospital are the ones that are in hospital, and trying to encourage probably a slightly different risk approach to discharge. Sometimes our staff can be quite maternal and paternal, and actually we know that hospitals aren't always the safest place for patients to be, so that made a difference. In terms of there were bottlenecks, so points of constraint in the service. Some of that was a change in pathway because of the amount of time it would take to isolate a patient. It almost became easier when everyone was the suspected COVID than when there was a mixture of some and not. So the stepping up and stepping down has been the hardest part of the pathways. When actually the community prevalence was so high, you treated everyone as a suspected COVID positive patient, so they kind of came in the same route. We had so many changes to the environment in at the front door, so at the emergency end, to make sure that we didn't inadvertently put another patient at risk by putting them next to a patient who is COVID positive. That definitely had some challenges, but also we tried to work with the London Ambulance Service to be able to provide mutual aid for other hospitals. So if we were under less pressure, and we're right in the centre of London, our local population is a bit less dense than other parts of our system, then we tried to ask for those patients to be redirected to our emergency department, because we were able to offload ambulances sooner. And that's the sort of mutual aid that I think has made a really big difference.
Yeah, I will translate it again in Dutch, Flo, en dan ja, wat ze eigenlijk ook vertelt is dat er heel veel samengewerkt is in de keten, en dat ook onwijs cruciaal is, ja, zeker met zoveel veel drukte, dat je heel goed moet nadenken. Hè? Enerzijds ook van ja, welke mensen hebben baat bij een ziekenhuisopname, en als ze dat niet hebben, dat je eigenlijk ook heel erg zou moeten kijken van hoe kan je dat dan ook in de wijk of in de wijk of elders oplossen. Ze is ook heel erg trots op eigenlijk wat er bereikt is. Hè, zo'n samenwerking hebben we eigenlijk nog nooit gehad. We hebben elkaar ook heel erg, wel echt heel erg geholpen. En ook heel erg met elkaar gekeken van hoe kunnen we dat ook echt samen doen. Ja, ik vind dat ook wel vanuit de NHS gebeurt dat ook nog wel misschien nog wel wat meer dan dat we dat helemaal gewend zijn in Nederland. Wat ze ook wel benoemd is. We hebben ook gekeken van hoe kun je nou mensen eerder met ontslag laten gaan. Dus ook wel de eisen. Normaal zou je misschien mensen wat langer in het ziekenhuis laten liggen. Maar nu zorg je er ook voor dat ze misschien wat eerder ook met ontslag kunnen. En die ambulances die stonden inderdaad voor de deur. En eigenlijk zijn er heel veel redenen. Inderdaad mensen die dus wat je kan doen om dat te voorkomen. Dus inderdaad dat van care planning in de thuissituatie. Kijken inderdaad is het echt nodig. Maar ook zorgen als mensen eenmaal binnenkomen, ze allemaal als besmet behandelen. Omdat eenmaal de prevalentie van het virus dan ontzettend hoog is. Nou, in ieder geval benadrukt het ook heel erg het belang van de samenwerking in de keten. En dit met elkaar ook met elkaar die samenwerking te zoeken. Flo, so you have like some recommendations, a top 5 for us, and one of the things a lot of people are curious about, because you are like ahead in the vaccinations for us. Oh yeah, you have it on the slide as well. So and we are really wondering, like, do you see effects already from that? So that is something. So what is your top 5 tips to us?
Yeah, it's really hard. Even since I wrote this, I was thinking of other things, but I think my observations, and they're my personal observations, has been, and in no particular order, so visible leadership. So we know that some of our staff were shielding and weren't able to come to work, but they still did some fantastic work behind the scenes to help. We're lucky that MS Teams seems to have completely changed our lives. only from the waist upwards, our clothing as well, but it's been fantastic. So I couldn't talk about this and not talk about Marcel, not just because he's Dutch and he's fabulous, but because he has been just at the elbow, feeling and working alongside a lot of the clinical staff. So really understood what some of the what it felt like to be working in this pandemic, and he's also very brave. You all know him. He's very direct and he's very honest, and he's very brave. And actually, we needed to be brave with some of the decisions we made, and them being made by somebody with a clinical background helped us enormously.
Yeah.
He's also willing to share the space, so that we made room for so the teamwork element was at every level. So we had room for other subject matter experts to come to the table and tell us what they thought was the right thing to do, probably similar to what we've done at times with people like Chris Whitty, who is actually one of our doctors. So it is about listening to people who know more than you do around certain things, and then helping to kind of either give them air cover or do the right thing. But teamwork, without a doubt, has been has made the biggest difference. And we're kind of nervous at the moment because some people are going back, and we want to maintain the good stuff about that. Communications. Marcel would say that there's only two forms of communications, too much and not enough. We recognise that. We recognise that we had to make up, with higher levels of uncertainty, we had to make ourselves more available to hear what people wanted to ask us. So it wasn't just about sharing information every day, but it was about having live briefings. We still do those every 2 weeks now, but they were weekly, or more frequent if there was something that had significantly changed that would have an impact on us. Great opportunities around research and innovation. So not just linked to the vaccine, but devices, Cpap devices. When there was a threat that there might not be enough, we were converting domiciliary home devices into devices that you could use in an inpatient setting. Lots of trials, lots of opportunities to also give people confidence around the fact that we weren't going to be here forever. And I have to say, top 5 has to be the vaccination programme. Having vaccinated such a high proportion, it's over 40% of our adult population, and I'm losing track because it's every day. We've just opened another max vaccination site local to our patients and population.
Can you already see the impact, like the pressure on the,
100%. So I know there's lots of research. I know there's lots of threats of strains, and you've got us with the UK strain. There's also a South Africa strain. There was a Brazilian. There's lots of kind of threats around that. But what we have seen is a significant reduction in the age of people coming in even during the second peak, with less coming in from nursing homes, and then less coming in for the over 70s and less coming in for the over 60s. So I look forward to seeing more and more of the research. We've certainly seen some already that showed the age of the hospitalisations and the really sick, patient. I don't think we have seen anyone be hospitalised who's also had the vaccine, unless they've only had it in a very short space of time. But that's the research. We're just waiting to get the answers to that. But I understand that as of quite recently, we hadn't seen anyone become really, really poorly if they'd had the vaccination. The reason I say cautiously there is because I know that if people have had it very early on and haven't had the chance to be able to respond to it, then there may well be some patients in that category. But that we absolutely believe that that's made a really big difference.
But that's such a reassuring news, and we kind of like envy the UK for being so far.
Something we could be envied over.
Yeah. Okay, yeah. But
that's
also like, so you have already vaccinated like 40% of your population, right? And then you just see really lowering down the numbers of patients in being hospitalized who have been vaccinated. So that is really like something for us to look forward to, because we are not yet there, and that's also probably why we can expect a third wave. Hopefully we are there like the end of May, the 40%, hopefully sooner, but this is actually the reality. And what I will do, Flo, is again translate it into Dutch, and then we'll go into the questions. So I've seen a lot of questions coming by. Dus eigenlijk wat ze zegt, een aantal hele belangrijke lessen. Het zichtbare leiderschap, wat zij heel erg heeft ervaren, ook samen met Marcel Levy, is dat er zowel vanuit verpleegkundig als vanuit medisch perspectief echt leiding, dat het echt een gezamenlijke effort was. Dat het heel erg belangrijk is om ook goed te communiceren over wat er gebeurt. Dat zei ze eerder ook al, van ook laten weten van het kan zijn dat het niet lukt om alles te doen, om alle zorg te geven, maar dan nog doe je het goed. Dat soort informatie, ook wat er gebeurt. Het teamwork, dat heeft ze eigenlijk ook al een aantal keer benadrukt. En het onderzoek ook, wat het heeft opgeleverd. En wat zij daarover zegt ook is, we hebben eigenlijk ook wel, behalve de vaccins en heel veel onderzoek over het virus, hebben we ook wel gezien hoe kunnen we nou bijvoorbeeld technologie gebruiken om thuis beter te monitoren. En het allerbeste nieuws is dus het nieuws over de vaccinaties. Dat zij nu op ongeveer 40% zitten van de mensen, van de volwassenen die gevaccineerd zijn. En zij hebben eigenlijk nu gezien dat die vaccinaties leiden tot minder ziekenhuisopnames. Dus dat ze van de 80, 70 en 60-jarigen nu veel minder mensen in het ziekenhuis zien die opgenomen worden. En dat daardoor ook de druk afneemt. En dat zien wij natuurlijk in Nederland ook al gebeuren in de verpleeghuizen, waar zowel medewerkers als bewoners nu gevaccineerd zijn, waar je gewoon nu ook minder besmettingen ziet. Dus dat is wel in ieder geval een heel erg positief punt. Misschien voordat we naar de vragen gaan, Sebastiaan, zou jij nog naar de volgende slide kunnen gaan? Wat misschien nog goed is om mee te geven, is dat wij vanuit V&VN de afgelopen weken ook heel erg bezig zijn geweest op voorbereiden op fase 3 code zwart. En code zwart is eigenlijk de fase waarin ze in Engeland eigenlijk net niet gekomen zijn, waarbij je eigenlijk niet meer de zorg kan leveren zoals je dat graag zou willen doen. Dus fase 1 is de zorg zoals je dat normaal biedt. Fase 2 is opgeschaalde zorg. Dus wat je ziet, dat je extra patiënten in het ziekenhuis krijgt, maar ook in de wijkverpleging. Dat je een aantal dingen ook niet meer kan doen. En code zwart is eigenlijk echt een crisissituatie waarin je bijvoorbeeld keuzes moet maken wie je naar het ziekenhuis stuurt. Wat we gedaan hebben is ook een themapagina gemaakt waarin je veel meer informatie kan vinden over die fases en ook voor de verschillende settingen. Dus het verpleeghuis, de wijkverpleging, de verstandelijk gehandicaptenzorg, de ziekenhuizen. Daar kun je allerlei informatie vinden. En ook de vraag, heb je vragen hierover, mail ons ook. Het mailadres kun je ook vinden op deze site. En we zijn van harte bereid om ook daar vragen over te beantwoorden, dingen uit te zoeken. Je kan er ook dingen terugvinden over de inspectie en hoe wordt toezicht gehouden bijvoorbeeld. Wat betekent het voor tuchtrecht? We hopen dat dat in ieder geval informatie biedt die jullie nodig hebben om je werk goed te doen of goed te kunnen voorbereiden. En dan wil ik overswitchen nog voor het laatst naar een aantal vragen die er zijn. Er zijn heel veel gesteld, we kunnen ze helaas niet allemaal beantwoorden. Wat we wel gaan doen is ze verzamelen en kijken of we nog op een andere manier de vragen kunnen beantwoorden. Want ik zag er heel veel voorbij komen die heel relevant zijn. Flo, so we'll go back then to we have some time for questions. So you were asked a lot. So there's a lot of questions in the chat, and I think Tiana, you will you have selected some of the questions.
Yes. Yeah, so I've looked at questions that were asked very frequently. One of the questions that was asked is about the ratio you had of staff versus patients, whether extra like non-specialized nursing staff or caring staff in the hospital, and what effect did that have during this wave?
Thank you, Tiana. So the ratios were changed quite a lot. So we tried to maintain a 1-to-1 in our single rooms. That was the bit we were most worried about, because we were concerned that that it was quite isolating. But we tried to open up environments that allowed us to have a very different ratio. At times we had four patients for one registered ITU experienced nurse, with the rest as registered professionals. So, as I say, some that had worked in the first wave, some that had come from other specialist hospitals, but perhaps had worked in children's ITU units, and others helping to support. Many of our medical staff helped to be one of those at the bedside registered professional, so undertaking that duties. The critical care nurses were amazing. They were very good. Initially they found it a bit difficult to delegate. I don't think it was just to me as the chief nurse, because I said, tell me whatever you want me to do, I'll do. But once they got into the rhythm and how the person arrived, really willing to help, really willing to learn, made a massive difference. So there were times where it was incredibly carried a big burden for the critical care nurses to feel responsible for such a large number of patients, but they were they had some brilliant registered professionals with them. So tough.
Yeah, and a question that a lot of people also ask, which is kind of similar, or at least I think it kind of fits with this question, is that a lot of people were wondering what kind of training was necessary for the staff. I think all across the board, because of all the symptoms that were there. So do you have any tips on that and any experience?
Thank you. So we did a lot that was delivered by critical care staff. We had, if you saw the early slide I had, we had quite a quiet summer before we were able to switch back surgery on. We used that time to train as many people as we could in the fundamentals of critical care. There was also some courses available that were delivered by our Health Education England for London. Some staff accessed that. Most of it was similar to skills and drills, either in the clinical environment or in a simulation environment. So we did a lot of intensive, almost like boot camp training sessions for our staff. But none of that replaces. We know we've got more to do there. We're trying to invest in dual qualifications, or qualifications in specialty, which is what we're pushing for in the UK, to be able to offer that not just for staff within the critical care unit, but outside, so that they will have a dual qualification, so that we don't have to rely on a crisis before we encourage people to work quite differently.
Great. I think final question, I'm looking at Bianca, maybe we can do one more.
Yeah, Tiana, there's one question about the Cpap or OptiFlow. So
yeah.
Flow, I did ask you that last week, so maybe I translated this wrong. So I thought it was like, so we have the OptiFlow use in a lot of, so at the COVID units. So what is the difference with the Cpap? Did I translate it? I thought it was the same, but maybe I translated it wrong.
So so just a different type of device, and so we use non-invasive ventilation. So which is some people call it Cpap, some call it OptiFlow, just different devices, but basically pressurized oxygenation through a mask without a tube being inserted into the throat. So we had two specialist areas where we were able to offer that care, and up to 34 beds across those. One was our infectious diseases unit, which is also a respiratory unit, And then we opened an emergency care unit, which also specialised, and they were often where our most medically unwell patients come through anyway via the emergency department, the A&E department. So they would often go to that unit anyway. So we had a really good base of skills there. So we were trying to, whatever decision we made, we were trying to build on what we already had, rather and actually use the staff as that kind of foundation rather than the environment.
Yeah, okay, and that's clear because I wasn't so very sure. There were several questions about it, so I was like, okay. So I think this is the end of the webinar. I really want to thank you very much, Flo. It was a real pleasure to have you, and also that you shared your experiences with us. Yeah, it's kind of reassuring that the vaccinations are starting to work, so that you actually see the numbers going down. There were some questions like if we are expecting in the Netherlands that could be an effect as well. Yeah, if we can postpone like the third wave, like the effect of the vaccinations will become higher, and but we are not yet there where the UK is, so that's a challenge. I think we've learned a lot from you. Also, that's for me, it's kind of also reassuring that that the preparations you had in the first wave and the teamwork, and that has helped you also in this like massive second wave. So we really hope we will not get into that like phase 3 code, what we call code black. And that we can postpone it. But it has given us a lot of insight. So I really want to thank you. Say hi to Marcel from us. Oh yeah, he's coming back. So he's coming back to the Netherlands. I know. Sorry for that.
Yeah, it's a sadness, but it's great that we've had the opportunity. I want to say thank you as well. So the conversations we've had have been really helpful for us as well. So we're always learning from each other. So sometimes it's just about reassuring each other that it's going to be okay. There's been a lot of that. So thank you as well to you and the team. Wonderful to me.
Yeah, you're welcome. So maybe for the people that were here tonight, thank you very much for being present. Again, if you want to know more, visit the website to see what is out there. If you have questions, there's an email also that you can reach us. And what we are, somebody says you can do this in Dutch. Wait, I will switch over. Ik wil jullie heel erg bedanken. Sorry, dat is omdat ik de hele avond tussen Engels en Nederlands switch. Ik wil jullie heel erg bedanken dat jullie hier vanavond waren. Ik hoop dat jullie het informatief vonden, dat jullie ook dingen mee kunnen nemen voor je eigen praktijk, waar je ook werkt. Zoals ik net in het Engels zei, kijk ook op de website. Daar zie je voor verschillende sectoren, voor het ziekenhuis, de wijk, de ouderenzorg. Daar hebben we de plannen uitgewerkt. Heb je vragen, mail ons. Wat we zullen proberen is de vragen die er zijn, om die nog te kunnen beantwoorden. Nogmaals bedankt dat jullie hier vanavond waren. En vul de evaluatie ook in. Er zit een linkje als het goed is. Misschien even aan Mieke of Tiana. Zit die link nu in de chat of krijgen jullie die in de e-mail?
De link staat in de chat op dit moment.
Ja, dus de vraag inderdaad of jullie hem in de chat willen invullen. Zodat we ook weten van, moeten we dit soort bijeenkomsten nu vaker organiseren, ja of nee? Dank jullie wel.